All right, good afternoon. My name is Dr. Stephen Little. It's my pleasure to introduce the topic and the speakers for today's multi-modality imaging grand rounds. Dr. Shaw, thank you for joining us as well. Today, discussing multi-modality imaging case rounds, we have Dr. Dixitha Anagula and Priscilla Wesley. They're going to take us through a fascinating case that has both echo and other modality elements. So without further ado, Dixitha, come on up here and show us.
Thank you for the kind introduction, Dr. Lil. We have no disclosures. Throughout the year, our faculty have done an exceptional job in teaching us multimodality approach to isolated and mixed valve disease. For the next hour, we would like to apply this learning to a complex valvular case and what we would do in a real-world scenario. A 77-year-old male presented to the emergency room for evaluation of shortness of breath. He had a history of hypertension and chronic obstructive pulmonary disease. This was at an outside hospital, and his cardiac evaluation revealed atrial fibrillation on electrocardiogram. His echocardiogram showed normal LV and RV function, moderate to severe mitral regurgitation, mild tricuspid, and mild aortic regurgitation. He had a nuclear SPECT study which showed normal myocardial perfusion. This was followed by a cardiac catheterization, which was at that time performed to assess the severity of the mitral regurgitation. And he had, the patient had normal coronaries with moderate to severe mitral regurgitation on the LV gram, and there was no gradient across the aortic valve. At this point, the patient was optimized for his heart failure symptoms and referred to our valve clinic. As we all know, the first thing that we do in our valve clinic, echo first. So we review the transthoracic echocardiogram that was done at our institution. We have a parasternal long axis view here where we see our we get a hint of our LV looks preserved, and our mitral and aortic valves here look like they're thickened. And moving on to the color Doppler of the mitral and aortic valve, we see some aortic regurgitation. We get a hint of mitral regurgitation, maybe an eccentric mitral regurgitation. So we want to look into this more. Moving on to our apical views, we see a significant mitral regurgitation on the color Doppler that's sweeping the wall of the LA all the way into the roof of the LA with a significant signal intensity on the spectral Doppler suggestive of hemodynamically significant mitral regurgitation. Evaluating our aortic regurgitation that we saw in our initial views, the color Dopplers suggestive of a mild aortic regurgitation, and the spectral Doppler slope is suggestive of a maybe mild to moderate aortic regurgitation. We also had some volumetric assessment on this patient with biplane EF using our apical 4-chamber and 2-chamber views, where we were able to get our LV stroke volume, and using our LVOT stroke volume using the spectral Doppler, we got a mitral regurgitation volume of 66 ml and a fraction of 46%. Overall, the transthoracic echo was reported to be a hemodynamically significant mitral regurgitation with a recommendation to follow up with a transesophageal echocardiogram to evaluate further the pathology of the mitral valve and also to look at the mitral valve regurgitation severity. These are the exact notes that are actually taken from the valve clinic progress note from that day, and I would like to bring your attention to each one of these points. It is utmost important to first evaluate the symptoms of the patient. What is this valvular lesion doing to our patient? The significance of the disease, and then also review the images of the studies, imaging studies that were done at our institution or elsewhere. This is one of the crucial things that we do in our clinics, maybe valve clinic or general clinic, always personally review the images itself. And other than just talking about the fixing the valve itself or what would be the management for the valve, it's very important to also focus on symptomatically treating the patient, which was done here, where salt restriction and fluid intake restriction was recommended. And at this point of time, a cardiac MRI was ordered for a mitral regurgitation quantification. Also on the same day, as a part of the comprehensive valve clinic assessment, The patient also saw CV surgery who discussed the risk versus benefits of different management strategies as in mitral clip versus surgically fixing the valve or medical management, and the patient decided to proceed with a mitral clip. We will now look at the cardiac MRI that was done on the patient. Here we have cine SSFP images of this patient, and we see a 3-chamber view here, which is similar to our parasternal long axis view or apical 3-chamber view, followed by a 4-chamber view and 2-chamber LA and LV. And then we have the unique view that we usually routinely do on our cardiac MRI, the RVOT view, with the tricuspid valve on the left side and pulmonic valve on the right side. Right off the bat, we see that the patient has a signal void that is in the left atrium, very eccentric jet that is suggestive of a significant mitral regurgitation. And there's also signal void in the LVOT that is suggestive of aortic regurgitation. Looking at the mitral valve itself, we see there is probably some prolapse of that anterior mitral leaflet with a possible flail. It's not as straightforward to call a flail on cardiac MRI because the regurgitation jet itself can cause some dephasing effect. That's an artifact that we see, and it's not a straightforward answer to say that this is a flail, but how eccentric the jet looks on this particular view, it is very suggestive of a flail. Moving on to quantification of valvular regurgitation by cardiac MRI. We have dwelled over this in the past, and I would like to go back and do a recap on how we approach isolated aortic valve regurgitation. When we have multivalvular disease, we want to focus on one valve and move to the next valve. So here we start with aortic valve regurgitation, and we quantify the aortic regurgitation volume using a direct measurement of regurgitant flow. So here we have the phase contrast images, which is a velocity mapping of the flow perpendicular to the region of interest. And here the region of interest that we are looking at is upstream to the aortic valve. We usually use ascending aorta or SDJ to calculate that direct aortic regurgitation on the phase contrast. And here we are seeing a reverse flow of 70 ml, and that accounts to a regurgitation fraction of 51%. How do we know it's real? Is this indeed a severe aortic regurgitation? We don't want to get fixated on just one method. We want to look at more than one method, especially in this complex cases. We want to use all the tools that we have on CMR. And there's other methods that we use. The indirect method that we use is LVOT forward flow. And if in the absence of any net intracardiac shunt, we can use the pulmonic net flow, which is usually within 5% difference of error from our aortic flow. And the difference between the LVOT forward flow and pulmonic net flow will give you your aortic regurgitation volume. So in this particular patient, using the indirect method, we were not too far off from what we got from our direct aortic regurgitation. There's other semi-quantitative methods that we can also use. One is the anatomic regurgitant orifice area. And in this particular study, ARO more than 0.28 had more than 90% sensitivity or specificity for a significant, more than grade 3 aortic regurgitation. And in our patient, we had ARO of 0.3, and I was being conservative with the measurement that we got here. And then we also look at the flow reversal in the descending aorta, similar to what we see on echocardiogram. And any holodiastolic flow reversal with a minimum flow of 10 ml per second that persists throughout the entirety of diastole is considered significant, which our patient had. So we have not just one, but more than one different way to assess this, and so far it looks pretty convincing that our patient does have significant aortic regurgitation. And our volumes are all consistent with each other using different methods. Moving on to the quantification of the mitral regurgitation severity, the mitral regurgitation volume is the difference between your LV stroke volume and your aortic forward flow. Your LV only has two places where it can, where the volume is going to, in the absence of any net intracardiac shunt. So either the LV volume goes into via your aortic valve or through your mitral valve. And then we are able to get LV stroke volume using our short axis planimetry, where we do stacks of our short axis from base to the apex, and we are able to calculate the LV stroke volume using Simpson's rule with our end diastolic and end systolic tracings, which accounts to our LV stroke volume. And we already got our aortic forward flow from our phase contrast data, which accounts to our MR here, which is here a 65 ml, suggestive of a severe mitral regurgitation. Moving on to the quantification of mitral regurgitation severity with mitral regurgitation fraction. The fraction is mitral regurgitation volume by your LV stroke volume. I would like to pause here and ask how many of you agree with this with the estimated regurgitation volume and fraction that we got here? There must be a catch if I'm asking, right? So that's not what our regurgitation fraction is. This is only in the absence of any concomitant left-sided valve lesions. And in this patient, we saw that there was significant aortic regurgitation, so we want to be able to account to that. So going back to what Dr. Little and Dr. Shah taught us during the multivalvular disease conference we had previously, it's important to keep in mind these two principles before we start calculating and putting numbers in there. We want to solve for flow in all the chambers we can, as many chambers as we can. And the first principle, the main thing is, in the absence of any significant regurgitation, your LV stroke volume, RV stroke volume, aortic forward flow, and PA forward flow are all the same. However, in the presence of regurgitation, your aortic forward flow, there's two components to it. There's systemic flow and aortic regurgitation. Similarly, in your pulmonic forward flow, you have your systemic flow and your pulmonic regurgitation. For our LV stroke volume, it's systemic flow, aortic regurgitation, and mitral regurgitation. So this is where our mitral regurgitation fraction calculation comes into play, where we want to account for that significant aortic regurgitation that we are seeing. So for mixed mitral regurgitation, aortic regurgitation, the mitral regurgitation volume, for fraction, the mitral regurgitation volume by LV stroke volume and accounting for that aortic regurgitation volume. And this can be used in the presence of coexisting right-sided lesions. They don't have any impact, the TR or PR don't have any impact on the left-sided lesions when we are using this formula. And for the TR and PR can also be calculated in the same method as we are using for MR and AR here. So we have now established that this patient has severe mitral regurgitation and aortic regurgitation. The mitral regurgitation itself, we think, is from a possible flail leaflet. And the aortic regurgitation, the patient's aorta was a little dilated, 4.3, and we don't know for sure what exactly the pathology is at this point. Before this cardiac MRI was reviewed in the valve clinic and the plan was made for the patient had a readmission again for heart failure symptoms. And this time around, a transesophageal echocardiogram was performed to assess the severity of AI and also look into the pathology more. And I would like to ask Priscilla to join us to show the transesophageal echocardiogram and talk more about the management of this complex valve case.
Thank you, Dikshita, for masterfully showing us the methods of valve assessment with CMR. So we go on to our first TE view for this patient. So this is the mid-esophageal long axis view, which shows us a ventricular arterial dilatation or an annular dilatation. You see a normal leaflet motion. So this is a Carpentier 1C, and you see a coaptation defect. I've given a snapshot of the coaptation defect in the long axis view. And this is the short axis view, which also shows us the coaptation defect here. The blood pressure during this TEE was 179/77. So this is the color flow Doppler across the long axis view, across the aortic valve in the long axis view. And the patient was in AFib. The RR interval was not that varying, but there was some varying between RR interval. His heart rate was in the 50s, which continued to remain the same heart rate during CMR acquisition, TTE, as well as TE. The vena contracta here measured about 0.65 in one of the RR intervals and up to 0.7 in some RR interval. And you again see in the short axis view that's a larger flow convergence or a large vena contracta that we can see in the still image. So what happened with the first TTE acquisition? Why is it that we were not able to see that significant aortic regurgitation? So these are a few points that I thought about, which is the size of the regurgitation jet we know depends on hemodynamic conditions, instrument settings, and also the hydrodynamic factors such as the jet interaction with the receiving chambers. So going through each of those characteristics, one of them was instrument settings. So when you know, one is color Doppler. Color Doppler gain is a threshold-based technique such that a signal above a specific amplitude is displayed as color, and then below a specific amplitude is displayed as absence of color or just grayscale data. So we can see that at very low color gains, you will have almost no signal or lower signal. And so lower color gain can give you the appearance of a jet being very small as compared to a higher gain which can make the jet look much larger. So the technique to obtain an image would be to have a Nyquist limit of 50 to 60 centimeters per second and a color gain that just eliminates the random color speckles from non-moving regions. And when we look at the first, so also gain affects spectral Doppler images. So when you look at overall gain, on the left side of the image, you see the gain is lower, and so the peak velocity appears lower as compared to the middle portion of the image where this is obtained at an appropriate gain, and you see the full spectrum of velocities displaying many shades of gray without missing any important low amplitude information. We need to make sure the wall filter is also appropriate. This is overgained, which obscures the true envelope of the spectral Doppler. So when we go back to our initial TTE image, we see this is a parasternal long axis view. And if we know this patient has significant MR, we don't see color flow in the left atrium during systole. We also don't see flow in the LVOT. And this is the arch of the aorta where we see no color flow, so absence of color flow. Which tells you that the gain was lowered, and this is how an image of the ascending aorta would appear. This was done at a repeat TTE, so you can see there is color flow there. And when you look at the tissue gain, the TGC was much higher in the near field as compared to the distal field or the far field. The other factors affecting color Doppler or reducing jet area is lower momentum, lower with a smaller regurgitation orifice area, lower velocity, lower pressure gradient. The things that we did not have here, our jet was very central, so if an eccentric jet, it can appear smaller. Lower Doppler gain, which is what was seen in our TTE. Higher Nyquist limit, so our images were obtained at the correct Nyquist limit, and far field attenuation. Hemodynamic factors in specifically for aortic regurgitation is heart rate. So if you have someone with higher heart rate, you can see a lower regurgitation volume. But this patient's TTE was acquired at a heart rate between 55 to 60, and TE was also acquired at the same heart rate. Were there features that could have suggested a significant AI in the first TTE? So here we can see the LVOT VTI. So I traced one of the LVOT VTI. It comes to about 22 centimeter. The LVOT diameter was about 2.5 because of the dilatation. So a stroke volume of 108 ml in someone with severe MR should make you suspect that this could be a significant AI. The other is the RVOT VTI. You can see in comparison to the LVOT VTI, the RVOT VTI is very small. And when you look at this coaptation defect on short axis, this could have given us a hint. And the flow reversal, this was again not obtained appropriately. The wall filter was very high, so you cannot see the flow reversal almost towards during the whole duration of diastole, but there is some flow reversal seen. So going on to combined aortic and mitral regurgitation. So what is this is also called as multivalvular disease, which is either stenosis and regurgitation of a single valve, or it could be regurgitation of two separate valves like seen in our case. And this is highly prevalent. The challenge that we have is to assess the impact of the lesions on cardiac remodeling, ventricular function, and timing of intervention. When you have a predominant valve lesion, it's very easy to assess the symptoms and pathophysiology that correlate with that pure lesion. But in our patient that had both severe MR and severe AR with a mixed lesion, patient management becomes difficult. Combination of MR and AR, which is mitral regurgitation and aortic regurgitation, is relatively frequent but understudied. And because of this, guidelines are limited due to scarcity of data, especially there's nothing mentioned in the ACC-AHA guidelines regarding management of specifically AR and MR combined. When you look at prevalence, the combined AR-MR, the prevalence differs based on the years, the gender, and the age. In Framingham Heart Study, which was 1999, mean age was 54 years. Prevalence was higher in men at 10% compared to women, 8%. In the Cardia study, which was done in 2007, it's done in a younger population between 21 to 35. You can see it's a lower prevalence of 0.5%. This is combined AR and MR. There was a retrospective study with 756 patients done in 2010. And in these patients with severe AR, 3 plus MR was seen in 12%, but more than 2 plus was seen in 45%. In a Swedish registry, which was again done in 2010, 22% of patients had combined AR and MR. Another recent retrospective single center study from the Mayo Clinic with 1,239 patients with moderate to severe AR, the prevalence of greater than equal to moderate MR was 14%. What is the etiology for a multivalvular lesion? So it's most often acquired. Based on the EuroHeart survey from 2003, rheumatic fever was predominant in that survey. Degenerative was also highly prevalent. We know that the incidence of rheumatic heart disease has declined over the past few decades with the aging of the population of industrialized countries, which accounts for a shift towards degenerative without a global reduction in the overall prevalence of valvular heart disease. The other acquired etiology like infective endocarditis, radiation therapy, drug-induced, or inflammatory causes was much less frequent. This was, again, a study from the Mayo Clinic which looked at the etiology and mechanism of mitral regurgitation in patients with moderate to severe aortic regurgitation. And what we see here is of the 167 patients having AR plus greater than equal to moderate MR, 107 of them had functional MR, so majority was 64% functional, 36% was organic. And when you look at the leaflet motion based on the Carpentier classification, in functional MR was type 3B, which is restriction in systole. Motion is restricted in systole, and the most common cause was non-ischemic cardiomyopathy. In the organic mitral regurgitation, the most common mechanism or Carpentier classification was type 2, which is excessive leaflet motion, with the most common cause being degenerative, which was prolapse and flail. What is the pathophysiology of these mixed or multivalvular lesions? So we know that the hemodynamic and clinical consequence of any given valvular lesion is modulated by the presence of another stenotic or regurgitant lesion. Consequence depends on the complex interplay of several factors, and there's hemodynamic interactions that can impact the diagnosis of these mixed and multiple valvular heart disease. For example, mixed valve disease may be associated with an increased antegrade gradient and flow. The continuity equation becomes inapplicable when you have two left-sided lesions. Any severe valvular lesion, for example, severe AR, can worsen upstream lesions, downstream lesions, which is severe MR. And the pressure half time is invalid in these, or may be invalid in these situations when you have altered LV compliance and relaxation or abnormal LV filling pressures. So when you look at aortic regurgitation and mitral regurgitation combined, the pathophysiology, both of them increase the LV preload. So you have diastolic stress. And these increased preload from both AR and MR can result in accelerated LV dilatation and dysfunction as compared to someone with just pure AR or mitral regurgitation. And AR, in addition, has increased effect on afterload. So the same amount or the higher stroke volume has to be pumped during the same duration of systole, which can result in increased systolic hypertension, afterload increase, and this causes systolic stress. So there is both volume and pressure overload in these patients, and this can increase the LV size, increase wall thickness, causes usually eccentric LVH, and increased sphericity of the left ventricle. And with symptom onset, patients usually have reduced LV function. In patients with just pure aortic regurgitation, the mitral valve is competent and it protects the left atrium and pulmonary veins from the deleterious effects of increased LV pressure secondary to aortic regurgitation. But when you have a coexistent mitral regurgitation, this exacerbates the impact of LV volume and pressure overload on the left atrium, pulmonary circulation, and right chambers. Patients with this combination of valve lesions who are symptomatic have worse LV performance as compared to someone with just isolated aortic or mitral regurgitation. What is the impact on survival? So when you have combined aortic and mitral regurgitation, this is a retrospective cohort single center study from 1993 to 2007 with 756 patients severe AR, and about 45% of them had more than 2+. More than equal to 2+, and what we see is there's a progressive decrease in survival with each grade of MR in the whole cohort, as well as in surgically and medically treated subsets. The 5-year survival in these group 3 to 4+ MR was only 42% as compared to 0 to 2+ MR, which was 70%. And in this study, MR was an independent predictor of lower survival even after adjusting for other univariate predictors of survival. This is another recent study which looked at the survival impact on survival with these combined lesions stratified by the MR mechanism. So this is a retrospective study from 2004 to 2019 with moderate to severe chronic AR. Of the 1,239 patients, 86% of them had pure AR, and about 14% had combination, with 9% having AR and functional MR and 5% having AR and primary MR. And what we see here, the survival is worsening with when you have MR, and it's worse even worse with when you have functional MR. So even after adjusting for age and sex matched general population, the mortality remained worse in these two subset of population. What are the other diagnostic challenges with echo in these patients? So assessment is very complex when you have two valve lesions. In the presence of AR and MR, you have more LV dilatation. So this can increase your regurgitant orifice area, and so you have worsened or increased regurgitation volume, especially in secondary MR. And in patients with primary MR, because of the annular dilatation, the Barlow's prolapse can appear less pronounced. Pisa and vena contracta are less load dependent and can be useful in these situations as long as the AR is not eccentric and hitting on the flow convergence of the mitral regurgitation jet. Volumetric methods to assess can be challenging because left-sided assessment of forward flow is invalid as it includes both AR and MR, but if you have a good RVOT stroke volume to assess net forward flow, you could use that in this situation. And pressure half time can be inaccurate in assessing the severity of AR in these patients with multivalvular lesion. How do you manage these patients? There's nothing mentioned in the recent ACC-AH guidelines on managing combined AR and MR, but depending on the clinical scenario, you can have a management strategy adapted. So for our patient who had severe AR on MR and has symptomatic, once you have symptoms, the mortality is very high. It's more than 20% per year. And then you assess, the patient is assessed by a heart team, which is assessing the surgical risk, the age, frailty, natural history, likelihood and risk of intervention. And the recommendation is a double valve procedure if it's a low surgical risk. And for primary MR is a class 1 indication. And if you have a secondary MR, it's a class 2A indication. So regarding surgery, I just want to touch base on few points with double valve replacement. Most published results come from studies focusing on young patients who have rheumatic heart disease, where the older patients with degenerative disease who have longer history of valve regurgitation, lower life expectancy, more comorbidities as compared to the younger patients would benefit from these double valve surgery is largely unknown. In 1990, there was a study where they did a double valve replacement. Patients had significant lower post-op survival as compared to a single valve replacement. What about patients with high or prohibitive surgical risk, like our patient? So there's increasing number of patients with symptomatic severe aortic regurgitation who have excessive comorbidities or clinical condition that contraindicates open heart surgery, and then they are declined or managed conservatively, especially if they have aortic regurgitation. Based on the EuroHeart survey, there was 7.8% of patients with severe AR in whom there was an indication to intervene based on the guidelines, but because of their high surgical risk or prohibitive surgical risk, they did not receive any intervention. Percutaneous repair of mitral regurgitation in these patients is shown to be safe and efficacious, but in patients with native aortic regurgitation, TAVI had been discouraged because of specific anatomic features that can compromise success and safety. So what are the challenges for using transaortic valve implantation in patients with just native aortic regurgitations? Few of the challenges is it's a non-calcified leaflet, and this helps with inadequate anchoring, especially with the early generation TAVR valves. With the aortic root in pure aortic regurgitation, they are dilated, and so there's limited ability to oversize because we do not have a lot of sizes available. And then the stroke volume when a patient with aortic regurgitation is high, which results in less precise positioning as compared to someone with aortic stenosis. So despite these clinical and technical challenges, there's some evidence that TAVI may be feasible in patients with high surgical risk with native valve aortic regurgitation. So TAVI for aortic regurgitation has been a new frontier in the revolution of TAVI. We already know that TAVI valve were performed across the entire risk spectrum in patients with symptomatic aortic stenosis, but the strength of published data is considerably lower in patients with native aortic valve regurgitation than compared to someone with aortic stenosis. This is one of the first studies where TAVI was implanted for patients with pure aortic regurgitation, 42 patients of them, in 42 patients. About 31% of patients without any aortic calcification required a second valve implantation. So the chances of receiving a second valve was much higher, and the chances of having a PVL in these patients was also higher. Although this is encouraging with this study, the early generational valves had a lot of complication and also PVR. But with the newer generational valves, which has easy retrievability, repositioning capacity, external sealing cuff that helps with the PVL, and unique anchoring mechanisms, this can potentially overcome the challenges that were seen with the early generational TAVR. So this is a meta-analysis that looked at all the studies that had TAVR implantation in patients with aortic regurgitation. And what they found was that success rate for new generational TAVR devices was 90% as compared to an older generational devices, which was 67%. And it also the newer devices performed better in terms of outcomes, PVL, short and long-term mortality, and also major vascular complication. What does guidelines say about using TAVI valves for aortic regurgitation? So it mentions that it's challenging and there is risk with migration as well as significant paravalvular leak, and it's rarely feasible in carefully selected patients with severe aortic regurgitation and heart failure who have prohibitive surgical risk and in whom there is calcification and annular size is appropriate. Are there dedicated TAVR valves for pure aortic regurgitation? So there's two valves, which is the Jena valve. It's a porcine root self-expanding valve on a nitinol frame. And these have feelers here. And these feelers helps in clipping the device to the native leaflets. It also helps in commissural alignment. And so this valve was available as part of the ALIGN AR trial, which completed enrollment in September 2022. The early feasibility results was presented in TVT 2019, which showed that the success rate was 92%. With the early generational devices, the work-defined success was only 74%. And when you looked at 30-day mortality, which was 0, PVL was seen mild in 20% at 30 days, and 80% had no PVL. There's another valve called J valve, and this is a porcine aortic valve with self-expandable nitinol stent and has 3 U-shaped anchor rings, which is seen here. The valve is currently available in 5 sizes, and these have unique features that seems to solve the issue of valve embolization, and it's in particular these self-aligning anchor rings together with the self-expanding valve. It grasps the native aortic leaflets. This is available as part of the compassionate use, and the cases are approved as a case-by-case basis by the FDA. Which valve to choose first to treat when you have a multivalvular disease? So whichever is the predominant lesion. In our case, the patient had severe aortic regurgitation and mitral regurgitation, and he was symptomatic. So management decision was difficult. The way we thought through was if patients who receive TAVI for aortic regurgitation is usually part of trials, and they'll get excluded if the MR is significant. So that way, then you treat MR first. But in our case, we had a multidisciplinary discussion, and we decided to use the compassionate use access with the J valve. The reasoning being, this was one of the study done at our center, where this is a large single center study where patients were referred for CMR to evaluate AR or MR between 2008 and 2018, and only patients with a single valve lesion were included. What you see is the indexed LV volume, diameter, and mass. It increased progressively as the regurgitation became severe in both AR and MR. At milder regurgitations, the volumes and diameters were not significantly different between the MR and AR. However, at moderate and severe, you can see there was much higher remodeling seen in patients with AR, which is shown in green, as evidenced by elevated or increased indexed LV volumes and diameters. So based on this study, we see that AR causes more LV remodeling despite similar severity of MR, and this could be one of the reasons why we could address AR first. The other thought process was fixing mitral regurgitation can increase the stroke volume across the incompetent aortic valve, so fixing that would worsen the aortic regurgitation. And also in patients with secondary MR, and also based on our experience with aortic stenosis and mitral regurgitation, we fix the aortic valve and then reassess the mitral regurgitation to see if it's still severe. And this is mainly in patients with secondary MR. So it's important that these kind of patients are referred to a comprehensive valve center to make a multidisciplinary team discussion, which takes into account several factors in the clinic visit, which is including the individual risk profile, the long-term morbidity of multiple prostheses, and the natural history of each valvular lesion if left untreated. What is the role of CT in these patients? So this patient received CT, and the role has grown substantially. CT is now the gold standard for annular sizing for TAVR, determination for the risk of annular injury and coronary occlusion. It also helps provide coplanar fluoroscopic angle prediction in advance of the procedure. In addition to evaluation of coronaries, we also evaluate the peripheral access to see if it's suitable or if the TAVR is feasible in these patients. So going on to the intraprocedural TEE that was obtained when patients, the J valve was used for severe aortic regurgitation. So once the J valve is brought into the ascending aorta, the anchor rings here are opened above the aortic valve, and this permits anatomic self-alignment in the sinuses and helps in clasping of the native leaflets. The valve is then deployed, and you can see it here, without the need for pacing with a self-expanding mechanism, and that rings helps in capturing the native leaflets. So we aim for a position of 70 aortic and 30 ventricular. This is post-deployment TEE. What we see here is there is mild central and mild PVL, posterior paravalvular leak. In the same TEE that was obtained But in the same TEE that was obtained, what we see here is the mitral 3D, which shows a focal flail in A2 region, maybe more lateral side of A2 with severe mitral regurgitation. So patient was asked to follow up. A month later in clinic, he felt better. His symptoms had started to improve, and plan was to get him back to evaluate mitral regurgitation in few months. But he was lost to follow up, and he came back a year later with worsening fatigue, shortness of breath, increased with exertion, NYHA class 3 to 4, had lower extremity edema, and these symptoms were present and progressively worsening for the past 3 to 6 months. An echo was repeated, and echo showed severe mitral regurgitation, which was seen even at a month follow-up from the echo. And in these patients with high and prohibitive surgical risk, which was the initial clinic visit, and the surgery team had already seen him, cardiovascular team, and decided for a mitral clip. So he's higher prohibitive surgical risk, symptomatic MR. So just to go over the devices available for transcatheter edge-to-edge repair, we have two devices, the MitraClip and Pascal. MitraClip is the most widely used TEER devices, and we have the newer generation, which is the G4, which Dr. Goel has gone over this, and we have 4 sizes available. Then we have Pascal, which is approved for degenerative mitral regurgitation last year and is still in trial for secondary mitral regurgitation. These have 2 sizes available. So when we evaluate these patients, we try to evaluate to see which category of complexity this patient fits in. Our patient had a central A2P2. There was no calcification. Valve area was 6 centimeters square. Posterior leaflet was more than 10, and the flail gap was less than 10, and width was less than 15. So he had an optimum and ideal anatomy for MitraClip. So this is intraprocedural TE. Again, we see the focal flail at A2, and there is posteriorly directed severe mitral regurgitation. The LVOT VTI is shown here, and this is the mitral valve area, which shows an area of 6, mean gradient was 2. And we see the pulmonary vein, which is reversed, and both right upper and left upper pulmonary veins were reversed. This is intraprocedural. We see transeptal puncture on the left, where it's located superiorly and posteriorly. And once we are comfortable with the height, transeptal puncture is performed. The steerable guide catheter with the dilator is advanced, and then the clip delivery system exits the sheath. And once we have the clip open, we try to align it perpendicular to the coaptation line. And once we are comfortable with the alignment, the MitraClip is advanced below the leaflets. And once we are below the leaflets, we confirm orientation, make sure it's perpendicular to the alignment, and it's cutting the mitral regurgitation jet. And once we are in the satisfactory position, the grasping of leaflets is done, and we confirm the mitral gradient and residual mitral severity. And once we are comfortable with the gradient and severity and the grasp of the leaflets, the clip is released, and what we see here is there's trace to mild mitral regurgitation. On 3D, we see a good central tissue bridge with 2 orifices on either side, and there is trace to mild mitral regurgitation. There's iatrogenic ASD in this patient with left to right shunt. The LVOT VTI improved from 9.7 centimeter to an 18.9 centimeter. The mean gradient was 4 millimeters of mercury, and you can see the pulmonary veins there's no reversal seen. So back to our patient. So he received now a J valve and a MitraClip. So post TAVI and mitral TEER, what was the patient's outcome? And Dikshita will go over the rest.
Thank you for sharing the beautiful images and navigating us through the complexity of managing this multivalvular disease patient. We saw the complex procedures and excellent procedural success, but what does this entail for our patient? We have seen previously on a study from our center here that at similar regurgitation fraction, patients with aortic regurgitation had significantly greater LV size and mass compared to those with mitral regurgitation. Dr. Malafji et al. Recently on their study further expanded these observations, where 664 patients, of the 664 patients, 34% had AR and the remaining had primary mitral regurgitation. And among these patients with more than moderate regurgitation, the aortic regurgitation patients had a higher prevalence of eccentric hypertrophy, and for the MR patients, the higher prevalence was for normal geometry. It was reported that although the MR group had more severe disease, it was the AR group that had greater degree of remodeling, as quantified by larger LV end diastolic volume, end systolic volume, and higher LV mass. What do we know about reverse remodeling after fixing the valves? In this retrospective study of a total 246 patients, preoperative LVEF and LV end systolic dimension index were identified as independent predictors for reverse LV remodeling. Cardiac function was assessed with echocardiogram on this patient's before and 1 year after the aortic valve replacement. This is a surgical aortic valve replacement. And post-operative left ventricular ejection fraction increased significantly, and left ventricular end systolic dimension index and left ventricular mass decreased significantly after the aortic valve replacement. In a sub-analysis by Dr. Yang et al. With Mayo Clinic group, of the 650 patients, 234 patients had a follow-up transthoracic echocardiography at least 6 months post-procedure, and this showed significant LV reverse remodeling, as we can see here. There's not much data, as we know, on TAVR for aortic regurgitation. However, this particular study was done on 11 high-risk surgical patients with symptomatic, moderate, severe, or severe aortic regurgitation after a transfemoral Yana valve implantation, and a significant reduction in LV diastolic and systolic dimensions and LV mass was noted over 6 months. Moving on to the LV reverse remodeling after mitral valve transcatheter edge-to-edge repair, both the LV end diastolic volume index and LV end systolic volume index show a biphasic pattern, as we see here, with an early increase and then a subsequent decrease in the volumes. The left atrial volumes showed a steady decrease over 6 months period, whereas there was no significant change in LV ejection fraction. Reverse remodeling occurred in 50% of the patients. No remodeling occurred in 40% of the patients, and there was adverse remodeling in 8% of the patients. Further, they also looked at the relationship between different LV remodeling patterns and outcomes, which is depicted here. And patients with adverse remodeling died earlier and more frequently. Following up with the impact of fixing the valves for our patient on LV and on left ventricle and right ventricle for our patient, there was substantial reverse remodeling noted, as we can see here. Sorry about that. We're almost done. So to conclude, multivalvular lesion, particularly aortic regurgitation and mitral regurgitation, is common and we come across it. And the assessment, though, is complex and needs multiparametric and multimodality approach. Timely referral to a multidisciplinary valve team is very important. And the current guidelines do not mention much about the management of this combined mitral regurgitation and aortic regurgitation. Also, we have to be aware of the role of TAVI in pure aortic regurgitation and look out for the new advancements in this field. To end with, the treatment has always to be with a goal to promote reverse remodeling and improve the quality of life and survival for the patient. We would like to thank you all, and particularly our CV imaging faculty, for all the learning that we received. We're happy to take questions.
Okay. Well, first off, Dixita and Priscilla, I want to really congratulate you. I think this is really an outstanding presentation. I think you've started with a very interesting case, and you touched on a topic which I think really there's not that much that we know. And I think there's lots of opportunities, both from the standpoint of diagnosis, but also from the standpoint of management as well. So I congratulate you on that. Let me ask you, and I think to some extent, the management decisions were a little bit easier in the surgical era, where basically you said if the valve lesion is more than moderate and you're going in there to fix all the valve lesions you can. Now, with the staged approach, with these percutaneous approaches, should you just start with the most upstream lesion, fix that, come back later, see how the downstream lesions do? Because you've got the aortic, you've also got the mitral, but now you've also got the tricuspid as well that we need to think about. And the reality is that oftentimes fixing the upstream lesion may improve the further downstream lesions. I think you showed very nicely for this patient, even the right ventricle, you can see significant reverse remodeling of the right ventricle and improvement in RV function in this patient. And I suspect that if there was TR, that may have gotten better as well. So maybe tell us, what are you going to take as you go out into your practice? Because I'm sure you're going to encounter more and more of these patients. So how are you going to approach this?
based on our experience, especially because with the transcatheter, we have more experience with aortic stenosis and mitral regurgitation, we always fix the upstream lesion. And the reasoning behind, like you said, was to improve, because most of these patients have functional mitral regurgitation. The primary mitral regurgitation is a little more lower prevalence, and we hope to improve the LVDP and hope to improve the mitral regurgitation with some reverse remodeling that we can see with fixing aortic stenosis. So our experience is with that, and that has been taken over to manage with aortic regurgitation. But I think it's a case-by-case basis as to how to assess until we have enough data. Like, we don't have data of managing combined lesions together in one setting, especially with transcatheter. We have data from our center with AS and MR, but we don't have with AR and MR. And with the AS and MR together, there was higher in-hospital mortality and use of mechanical circulatory devices seen in those patients that was done together. So they were more sicker patients. But as you mentioned, in our case, the thought process was to fix the AR first, because we were hoping that if you fix the MR, the stroke volume would increase, and that could have worsened AR. But if a patient has to be qualified for a trial, because AR is still in trials, then MR would be a contraindication to be accepted into that trial. So we would have to fix the MR first to get the AR, to get the patient qualified for a trial. So I think so far it's just based on experience and some case reports. And
I'll just make another comment. So again, fabulous case. I particularly like the discussion of the remodeling and what happens with these two respective lesions. Just one caution around the notion that you don't do the mitral first, because by correcting or at least improving the mitral regurgitation, you change the stroke volume, but you also change the preload. So you lose all that extra preload from the MR, which is part of your stroke volume on the left, from the LV. So it's not entirely clear that that's the approach. The other thing is, practically, today at least, you often aren't faced with this dilemma for the reasons you said. I mean, the J valve or the Jenna valve are, the trial only or the compassionate use. And the other practical thing to know is that the incidence of non-calcified aortic valve dysfunction in typically the elderly who's high surgical risk is actually thankfully quite low. It's the lowest valve lesion we deal with, right? It's AS and MR, battling for first place, and then we've got a whole lot of TR, but thankfully, rarely we don't encounter the non-calcified significant AR in the elderly very often. And if we do, it's typically a bicuspid valve, which is another element of confusion.
Thank you for an amazing presentation. This is Grand Rounds material. And I cannot thank you for an amazing year that you spent, or more, depending. And I think the thought that you put in this one. My message to you and all is you addressed two different lesions, right, for valve regurgitation. And most frequently, we have combined lesions of the same valve. And actually, we don't have good recommendations for all of us regarding mixed lesions of an ASAR, MSMR, et cetera, et cetera. So the caution is these patients get symptomatic earlier than, and don't box them into the severity of regurgitation or severity of stenosis, because it's a pressure volume load depending where you are. And you have to listen to the patient, looks at some metabolic changes, BNP changes, pressure changes, below, meaning at the left atrium or pulmonary valve, and it is at times difficult. So most often you will intervene on these patients if they have moderate of both, as opposed to your typical, severe aortic stenosis or severe aortic, regurgitation, etc. So a word of caution, because we don't have as much data on these.
Thank you for the excellent comments.
Thank you.